Welcome back to Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Kentucky chapter of Physicians for a National Health Plan. Let me say up front, the views and opinions expressed on Single Payer Radio are those of the speakers and not the station. And if you have any comments about the show or would like to share your healthcare story, please send a note to Kay Tillow. She's the chairperson of Kentuckians for Single Payer. And I got this email address wrong our last episode. Here is Kay's correct email address. It's nursenpo@aol.com. That's nursenpo@aol.com. I'm Mark McKinley, a volunteer with Kentuckians for Single Payer, and I'm a sustaining member of Forward Radio. So let me just say up front, if you can, please become a sustainer. It's easy. Go to forwardradio.org and click on the donate button. Become part of the Forward Radio community. We're recording today's episode on May the 6th in our Hayburn studio. And until they decide otherwise, Dr. Michael Flynn and Dr. Eugene Shively will continue to lead the discussions of our healthcare systems. Both are retired surgeons with about 100 years of medical practice between the two of them, and both are professors emeritus at U of L School of Medicine. Dr. Flynn's practice was primarily in urban areas, and Dr. Shively's practice was primarily in rural parts of Kentucky. Welcome back, Dr. Flynn and Dr. Shively.
Thank you, Mark. It's good to be here again.
Thank you.
Okay, I thought today we would start with a discussion of some terms that can be confusing depending on what country you live in, who you're talking to, what some of the biases are. So, Dr. Flynn, can you start us off with
Well,
this?
no, before we do that again, I would like to make the disclaimer that I've made before that these views that are expressed here by me are my personal views and do not in any way reflect the views of the Department of Surgery or the University of Louisville.
Okay.
I would like to do the same. My views are my own. They don't reflect the Department of Surgery or the University of Louisville, nor do they reflect a Taylor Regional Hospital. I'd like to also say that some of our data is a moving target, and it's very difficult to get exact data. If anyone wants to dispute this, send us an email, and we can look it up, and we can discuss it at the next program.
Okay, that sounds good.
So let's let me suggest that we discuss take the first term, which is the public option, and address that.
Okay, sounds good.
And so let me make a statement about that, Gene, and then let you put your 2 cents in, and we'll see where we go from there. So this is basically a government-run, or the plan would be to have this be a government-run, either federal or state or even some combination, healthcare insurance plan for people under 65. This, from a funding standpoint, there basically are 3 options. There would be a plan in which it would be sustained by the premiums that would be paid by whoever happened to buy this public government-run health insurance. This could be tax subsidized. It could be some combination of a tax subsidy and a premium. And it could either be run by the federal government or the state government or some combination. So that's a starter.
And how would Obamacare fit into this, Mike?
Well, again, whatever we talk about here, whatever would the end product would be the result of whatever negotiations went on. Now, I would assume that whatever is left of the Affordable Care Act would in some way be dovetailed into this. This was the one component of the Affordable Care Act that, as we both know, was negotiated out when this was initially put into law back in, was it 2007 or 2008. And in addition to not having a public option, there was the for-profit insurance companies were given the opportunity to keep 20% of the revenue that passed through them, revenue which came from premiums that people were paying for administrative costs and profit, which is, we've said this before at these discussions, Medicare spends 2% of the revenue that goes through it on administrative costs and 98% on health care costs. So I don't know exactly how that would happen. Our goal here, I think, today is to try to give someone listening some idea of what these terms mean. And that's basically what the public option means. Now, how these things would all fit together would be the result of the political process, and how that political process would work out, would be depend on who's running the store. And so if you have the current administration, nothing's going to happen. If you had a Democrat in the White House and the Congress the way it is set up today, I'm not sure what they could work out. If you had a Democratic Congress, both houses, and a Democratic president, then I think you'd get more, something worked out that would be more beneficial to the public.
The way I understand it, if we have the current administration wins in November, we'll probably have more people with no insurance. If the Democrats won, the insurance companies are really very interested in this. They have already started a large lobby, and the last figure I saw was over $700,000 that's been donated to the Democratic Party. And of course, the insurance companies are very, very interested in getting at least their 20%.
So the beneficiaries of a public option, presumably added to whatever's left of the Affordable Care Act, would be citizens with poor, moderate incomes who either cannot afford private health insurance. They're either the underinsured or the uninsured, which is probably 70 million people in this country. People with pre-existing conditions whose private health insurance is very expensive. The young and the healthy, who often get poor quality, cheap plans that don't cover anything. When they get really sick, they've not got very good coverage. And the other issue is portability. So presumably this public option would be run in a way that if you are in Kentucky and got sick and you came from Florida, you could get your health care here and it would be covered, and you wouldn't have to have a huge amount of out-of-pocket costs, which is kind of what happens if in those sort of situations today.
Mike, let me just say that when you talk about beneficiaries of a public option system, I think private insurance companies would also benefit in that they would be able to cherry pick who they want for their plans, and folks going into the public option are probably higher cost patients with fewer resources that would opt for the public option. So again, I don't know if again, that's another discussion to have, but at least I think it allows private insurance companies off the hook with some of the higher cost patients they might be taking on.
I agree with you. That's one of the disadvantages of the public option. But if we're talking about defining a term of a public option, one of the advantages, a lot of these people could be covered. And, that's one of the major disadvantages, because if you have a young person with getting a cheaper plan, but at the same time, presumably, and again, we're talking about something that we're visualizing, but something that the end result isn't going to be, whatever that end result would be the result of a political process, and we really don't have any way of foreseeing how that would work out. But the premiums, presumably, of a public option would be a whole lot less than the premiums in the current for-profit health insurance, because it would be run by the government, which would be run as a not-for-profit. So you wouldn't have this 25-35% extraction of revenue that the for-profit insurance companies are keeping for everything from advertising to political contributions.
Right.
Well, Mike, what would happen to the people who already have insurance, like they work for Ford Motor Company? Would that stay the same?
I don't know. We're speculating about how something might turn out, and I think our goal here is to try to define a term, the public option, so that someone who doesn't quite understand it would have at least some idea what that would mean, which would again be a form of government-run insurance for people under 65. All of those different combinations or possibilities really aren't anything we have any more idea about than just the speculation of wondering how much influence the for-profit health insurance companies are going to have in getting politicians to do what something would do for their benefit, as opposed to making decisions for the public good.
I assume that they would cover all pre-existing conditions, or like Obamacare does.
Well, again, presumably those are supposedly the pre-existing conditions, the portability, and the more affordable premiums for people in lower and moderate income levels.
God, okay, excuse me just a sec. We want to get to rural health and its impact, and I don't want to rush through this, but I also know that we wanted to allow plenty of time, and Mike, we had some other terms that we wanted to get through as well.
Yes. A single payer system. Okay?
Okay.
That's something.
Yes.
One of the reasons we're all here. Well, again, this is a single public agency, a government, the federal or state government, which finances the health care, again, for all citizens. And we're sitting here explaining these things without knowing whatever would end up at the end of a political process. And as we go along a little bit, without spending too much time on it, again, this would be health care insurance, not health care delivery. So that the hospital in Campbellsville, Norton Hospital, University Hospital would still be run the same way. The pharmacies would be run the same way. The physicians' offices would be run the same way. The bill would go to this, whatever this was, whether run by the state or the the federal central government, and whether or not there were private for-profit insurance possibilities, that's an unknown. It would depend upon what the political ruling class would come up with at the time, if this ever becomes an option.
So give us an example of a single-payer system.
Well, there are a number of different countries have done it in different ways. 1948, in Britain, they established a National Health Service as funded by general taxation, and it covers everything. It runs the hospitals, it runs the physicians' offices, it runs the pharmacies, and there is private health insurance there if you want it. And I think we talked a little bit about this once before, about
Yes.
getting to the head of the line. So that's one example. Canada, they established a taxpayer-funded single-payer system in 1984, which covers hospital and doctor costs. So for dentistry and drugs and other things like that, you need to have some kind of employer plan, or you have to buy some other insurance. And health insurance, for-profit or private health insurance is available as well, in addition to the single-payer plan. And it's kind of a combination. The central government provides the money. The money is given to the provinces, and the province manage the healthcare delivery or the insurance delivery. But the hospitals, a friend of mine up in Hamilton, Ontario, at McMaster's University, the hospital and the university system functions the same way it did before this plan was established in 1984.
Well, Mike, when you talk about a single-payer system, our Medicare system
Yes.
is a single-payer system. Before it became as it's becoming more privatized,
yes, yeah.
it's publicly financed, privately delivered. Correct?
Yes. Well, another single-payer system, I guess it's a single-payer system, actually socialized medicine, is the military. The Army, the Navy, and the Air Force have their own system. It's totally funded by the government through the Department of Defense. They have hospitals. They have outpatient clinics. They have all of the specialty issues, the flight surgeons, and it doesn't cost any individual service member a dime, the drugs. And the VA is another example, which unfortunately is also being raided by privatization issues, but the way the VA was originally established was that this would cover the costs of Medicare to the veterans.
I need to point out, though, that Medicare only pays 80%. And so most people have supplemental insurance to cover that last 20%. And you can also buy insurance to cover Part D for your drugs, and then you can also buy a separate insurance to cover dental and vision. I think there are several things that at least I would like to see if we go to a single-payer system or a universal healthcare system. I think most Americans want to be able to choose their own doctor. I think that pre-existing conditions should be covered, and that there should be a strong individual mandate, and that if the insurance companies who the government contracts with should be regulated so that the prices don't go out of control.
where other countries have managed to do those kind of things. For example, Canada has a Ministry of Health, and the Ministry of Health reviews drugs. They review them for effectiveness, and they review them for cost. And other countries do the same things. For example, in Japan, they have universal coverage, and it's funded by multiple sources, including coming out of the employer, coming from the employee. There's some out-of-pocket costs. There are no for-profit hospitals. Health insurance is mandatory, and the fees are regulated. So, as we try to define these terms, what we see, we look around the world at these other 33 countries or 35 countries who have managed to do a better job providing health care than we have, is they've all done it in similar but somewhat different ways to accomplish the same thing.
The German system comes out of half from the employer, half from the employee. It's about 7.5%, and then the federal government subsidizes people who are disabled, who are impoverished, and can't buy their own insurance.
Now, guys, we've got about 40 minutes, less than 40 minutes to talk about rural health care.
Let me just make
Okay, sure.
one more quick comment about
Yes.
the definition of terms, because we're talking about the public option and a single payer system. And basically, the goal here is to provide universal health care for everyone. And the only other term that I just like to kind of drop in here very quickly is two-tiered health care, which is what goes on in a lot of places. And I think that whatever we end up with in this country, we're probably going to have some kind of two-tiered system where you have, hopefully we would have a very strong and dominant government-funded health care insurance program, but at the same time allows the other aspects of healthcare to exist. I think the political reality of trying to establish a system of healthcare that is completely run by the government, that just wipes out all of the for-profit health insurance companies, is unlikely to occur. And I think in the process, the political process of making these compromises, we're going to end up with something like that. So, and I think we've pretty much done the issue with the terms, don't you both? And we can kind of move on to
I think that
rural health.
the coronavirus is going to drive this issue because we're going to see a lot of people who can't afford medical care, and depending on the election in November, I think there will be a major issue in the political climate in Washington.
Well, most definitely. And Dr. Shavely, as we begin the discussion of healthcare in rural areas, can you start off by, are there any differences in population makeups of rural versus urban areas? Can you talk a little bit about that?
Yes. It depends on how you define rural.
Okay.
The federal government's got more than one definition. And part of those definitions is an area that's not urban.
Okay.
Well, that could be Cherokee Park.
Yes. It'd be Central Park in New York. But rural areas have an older population, a sicker population. There's a higher incidence in emphysema and COPD, higher incidence of hypertension, higher incidence of obesity, particularly in a state like Kentucky, and a higher incidence of diabetes. So we have a higher group of people who have chronic illnesses, and these people often do not get health care because there are less doctors and there's less access. And that situation is actually getting worse. Before the epidemic, it was estimated that approximately a fourth of rural hospitals were on the margin financially. I think we're going to see more after the epidemic. We've had several hospitals to close in Kentucky. Appalachian Regional Hospital last month furloughed a lot of employees. The hospital in Moorhead have also furloughed employees. I think most rural hospitals have furloughed some, but not as many as Appalachian Regional Hospital.
Gene, before I ask you a question, let me do two things. Make a statement about a historical background and then my very brief experience with rural hospitals. So background, the Hill-Burton Act, that was passed in 1946. This was a different country. We'd gone through a depression that was, I guess, a decade or so, and we had 40 years of World War II, and there was a sense of more kind of we're in it together than there seems to be today. It funded public nonprofit hospitals in rural communities and maybe some other medical facilities that, as Mark had asked about earlier. And they built a lot of hospitals in rural America, and many of those are in the South. And then back in the 80s, things started to change. My very limited experience with rural hospitals was when I was a resident at the University of Maryland in the mid-'60s, and we went on a rotation to the Peninsula General Hospital in Salisbury, Maryland, kind of like the rotation at U of L when you went out to Madisonville. And I remembered, I learned a couple of things from there. Number one, the importance of the hospital as an institution within the community, because there was the economic benefit of having this hospital there. The people worked in the hospital, the nurses, the laboratory technicians, the people that worked in the cafeteria, the janitors, and then the supplies, the food that they bought, the supply in the cafeteria. Somebody picked up the garbage. There was a lot of revenue generated. It was an important economic engine in this community in Salisbury, Maryland. The other thing I learned about it, I was taken duck hunting one morning. This is not a particularly rewarding experience for me by a couple of surgeons, and I mean I don't know if we even fired a gun at anything. There weren't any ducks, but one of the surgeons was explaining to me, and again this is back in the mid-'60s, how the importance of the presence of this hospital in this rural community, in that the other major employer in the community was a Wayne Pump Company. I don't know anything about Wayne Pump. I don't know what the pump looks like, but it was an important asset, and it was an employer. And what I learned at the time, or what I remembered, was one of the important components of attracting Wayne Pump to Salisbury, Maryland, was the fact that the Peninsula General Hospital was there. And so there's a lot of economic issues related to closing these hospitals.
It's a big economic issue. Classic example is near Ashland. Our Lady of Belafonte Hospital. It's a 214-bed hospital that closed in April, and they employed over 1,000 people. It was the largest employer in that county. It's going to create a tremendous problem. And where are these people going to get work? In our community, Taylor Regional Hospital is the second largest employer. We employ over 700 people. The largest employer is Amazon. There's a great big Amazon warehouse there that was one of the first warehouses of Amazon.
Dr. Shavely, when you talked about the closing of Our Lady of Belafonte up there in Ashland, is there another hospital there in Ashland?
Yes, there is.
Okay.
And hopefully they'll be able to cover the need. There's also a hospital across the river in Ohio, and there's also a hospital across in West Virginia. But you got to realize that Medicaid patients, most of the time, the hospitals across in other states will not get reimbursed for Medicaid unless it's something special.
Exactly. And with the soaring unemployment rates going on, I mean, and also the dire straits as far as the economics, hospitals needed every nickel, I guess, they could get. And now, what if somebody shows up at the door at King's Daughter? They have to provide care, and it might be uncompensated care. Is that how that works?
Yes, and not only is uncompensated care, but partially compensated care. For example, in eastern Kentucky, there are counties where over 90% of the patients are Medicare and Medicaid. They only pay about 80% of the cost. So most hospitals make that up with for-profit or with insurance companies that pay more. But if you don't have that reserve, then you don't get adequately compensated. That's one of the reasons that rural hospitals work on a margin. That creates another problem if you're working on a margin and you're competing for nurses in another community that has a hospital that's getting better compensated, you can't compete. We have that problem in Campbellsville. The hospitals at Hardin Memorial, at E-Town, the hospitals in Glasgow are able to pay the nurses more, so we have a lot of trouble competing. Now, it used to be that nurses wouldn't travel 40 to 50 miles to work, but that's changed. They will now. And I give you one example. Our hospital was paying a nurse that I know $23 an hour. She went 20 miles away to a for-profit hospital that was paying $35 an hour plus benefits. So that creates a real problem. We have a very nice hospital. We are a trauma center. We also have a good cancer center. We have excellent x-ray, and we have really good doctors. We have worked for over 40 years to establish that, but the issue is, how long are we going to be able to sustain that? When I came to Campbellsville 42 years ago, I was the second general surgeon, but 20 miles north of us, there were 3 general surgeons. Over in Greensburg, there was 1 general surgeon, and in Adair County, there was 1 general surgeon. These surgeons did practically everything. I mean, there were a few things they wouldn't do. They wouldn't do lung resections or radical pancreatectomies or esophagectomies, but they did gynecology, basic orthopedics like fractured hips and closed reductions. Now that is gone away. The general surgeons are not trained to do that, and most general surgeons wouldn't take on a large number of operations like that. That creates a problem for the rural hospital, particularly the critical access hospitals where we don't have people adequately trained. Another problem is obstetrics. Over half of the counties in the United States don't have anyone to deliver a baby. If you have to travel 40 or 50 miles to get your baby delivered, that creates a tremendous problems. A lot of people with preeclampsia, a lot of people go to premature labor or in sudden labor, and they can't get to the hospital.
So, in addition to OB, mental health is another issue that it becomes a real concern in rural areas, especially where hospitals are closing because there's nobody there.
Yes, it's not only a problem and where hospitals are closing, it's a problem that we have all the time. If we have a patient with mental health issues, we cannot get in-house psychiatry consultations. For example, if I have to operate on someone who has a mental health issue and they have a gallbladder that needs to come out, I cannot get in-house psychiatric consultation. I usually have to get one of the internists to help me out with that. We often have patients in the emergency room who have mental health issues, and we cannot find a place to transfer that patient. It's very difficult to get a patient into a mental health institution. We have state hospitals, but it's not easy to get those patients transferred to state hospitals.
Dr. Shively, what happens to these patients?
Sometimes they stay in the emergency room for a long period of time. Sometimes they're stabilized and they're discharged. We do have an outpatient psych unit, and the outpatient psych unit will evaluate these patients. They've increased their hours, and they will sometimes take care of them and then decide if they can find inpatient facility or just treat them as an outpatient.
You know, in the United Kingdom, rural hospitals are doing fine because they're run by the government based upon an assessment of local needs, as opposed to, and that was going to be my next question to you, is who makes the decision to close rural hospitals? But in Britain, they're running the whole system, and in many other countries, they decide to provide the health services based upon the needs of the community, as opposed to what I assume is either a corporate decision to close a hospital because it's not making enough money. Again, that's would be my next question to you. Who makes the decisions to close these hospitals? Because we're 25% of the, where we've lost, 150, 120 hospitals in this, rural hospitals in this country in the last, since the beginning of this century.
In Kentucky, I think 40% of the hospitals are a margin. Well, who decides to close a hospital? Well, it's very complicated. It depends on who owns them.
Yeah.
For example, over in Marion County, there's a hospital that's owned by a for-profit corporation. Now, they do have a psych unit. It's for geriatric psych, but we can't get a patient admitted in the middle of the night, but we can probably get a patient admitted in the daytime if they have beds. Now, that hospital, if they're not making money, they would be closed by the corporate headquarters. And their corporate headquarters is in Nashville. They own a lot of rural hospitals, and it's strictly for profit. The interesting thing about that hospital is not only is it for profit, but they've been bought out by an equity company whose, as you well know, main purpose is to make money. They also have a relationship with Duke University, which I don't know the details of. I'm trying to find out more about it. But so if they were to close, it would be based on how much money they're making, and it would be a corporate headquarters decision.
Now, this is an example, at least in my opinion, of how we have lost our moral compass in this country, where you've got hedge fund investors running for-profit hospitals in rural communities. I mean, it's just awful. Let me just twiddle the wheel just a little bit here. The hospitals that seem to be at most risk of closure are in states where they have not expanded Medicare. Texas, Tennessee, Oklahoma, Georgia, Alabama, and Missouri. Whereas in other states like Kentucky, because Governor Beshear, number one, expanded Medicare and at least provided some basis for the continued
It's Medicaid, right?
Medicaid. Did I say Medicare? Yeah, thank you.
Yes.
Okay.
Yeah,
Okay.
got my mouth was going faster than my brain.
Yes, Kentucky's expanded Medicaid, and it's helped a lot of rural hospitals. The other thing that's done, and both University of Kentucky and University of Louisville have actually studied this, and they did a study year before last that was presented at the Southern Surgical Association meeting, and then last year another study was presented at the Southern Surgical Association meeting, and that one of them was on cancer care of the colon, and they found out that the states that had expanded Medicaid, and they studied Kentucky, that there were more colonoscopies done, and there was earlier diagnosis of cancer than prior to that. The other study was on breast cancer. They found out that more mammograms were done. Breast cancer was discovered earlier, all based on expansion of Medicaid versus the time when it was not expanded. Now, you asked me a question, who closes hospitals? The other two reasons is we have two hospitals that surround us that are not-for-profit, and they're owned by a separate group, and those hospitals would be closed based on the group that runs that hospital. Now, they're kind of like Baptist and Norton's Hospital. They're not-for-profit. They're run by a board. And so if they got to the point that they were losing money, they would make a decision to close it. The hospital I work at is a separate taxing district. And that hospital could only be closed if the board, which is appointed by the fiscal court, but this board can only make decisions corporately. The fiscal court cannot go in and say, we don't like the way you're running the hospital, and fire the board. The hospital could only be sold or closed if the board unanimously decided to do that. It would then go back to the fiscal court, and then the fiscal court could do whatever they wanted to with it. Now, in Adair County, we have an extremely interesting situation. It kind of borderlines on Mitch McConnell's idea that states could go bankrupt. We had a healthcare district in Columbia that went bankrupt, and the bankruptcy judge decided that the hospital could be sold to another non-for-profit hospital in Glasgow. But the interesting part is he kept the hospital district to pay off the debts. So the people who live in Adair County are paying taxes to a hospital district, but they don't own the hospital, which is, I found, extremely interesting situation that I've never come across.
Yeah, when I was a resident at the University of Maryland and down at the the Peninsula General Hospital in the Eastern Shore of Maryland. That was a community hospital, and I don't. It's been so long, I don't know how all the different factions worked in it, but it was run, subsidized, and managed by the local community. Now, I don't know, was it fiscal court or the local government, and we started losing this sense of responsibility to deal with the local needs of a community in the 80s. And there's been this very slow evolutionary change from the Hill-Burton Act of 1946 to our patchwork system today, where the kinds of things you've described are just it's crazy. There is no system. This is just every man for himself.
Well, did a situation arise that municipalities said we don't want we don't want to raise taxes to pay for these hospitals, and so they wanted to go ahead and lift their, have somebody else take over some of these hospitals? How did?
Well, what I have seen from the 80s to today has been a general political inclination that taxes are too high, and this mostly means taxes for people who have more money than they can possibly spend in 12 lifetimes, and that they need to be given tax deductions. I mean, Reagan administration was doing this, Bush did it, and the tax cut for the rich and the corporations in December of 2017, which eliminated the individual mandate from the Affordable Care Act, did the same thing. So you've got the 1% or the 0.5% or the 2% that are getting richer and richer and richer in this country, and everybody else the crabs are all scrappling around down at the bottom of the barrel trying to figure out. And other countries don't do this. I mean, the other countries, all of these other 33, 35 first world countries that have got some kind of healthcare system that provides health care for all of their citizens. The millionaires haven't left France. Paris is a very expensive place. London is the same way, and they're there. They're still there. We were in London last last summer, and we went up to Bath and took a tour around the Cotswolds. And there was a little van there were 5 of us, and my wife and I and another couple and their son. And the driver was a young man named Nigel, who was about probably in his late 20s, and we got to talking a whole bunch of these things. And he says, I don't mind paying a little extra tax so everybody else can get health care. I mean, it's a really very simple concept, an idea, and it was very simply explained by this young man. And there's a lot of difference in the way people in countries feel about these things. And when you think about the really, really rich in this country and the issues going on with the coronavirus, where are they? Aside from Bill Gates, they're all hiding under their desks or locked into their castles and with the gates closed and just riding it out.
Now, another interesting problem is in Elizabethtown, Hardin Memorial Hospital. Hardin Memorial Hospital was owned by the county, and the fiscal court ran it. They have now sold that hospital to Baptist East, and I think it'll be concluded in December. there was a lawsuit tried to stop the sale of the hospital, but they failed. So that's going to go through, and Baptist East will own Hardin Memorial at the end of this year. If you study large hospital corporations, profit or not-for-profit, that take over small hospitals, usually what happens is they accumulate a lot of patients. They're therefore able to negotiate with insurance companies at a higher rate because they control so many patients and the cost goes up. Usually the small hospital goes down because the big hospital wants patients transferred to the mothership.
Well, and Mike, let me just go back to what you said. You shared what Nigel's perspective was, that there's a sense of solidarity among people. At least that was Nigel's view, that we're in this together, and here it's every person for themselves type situation, and how that developed during the Bevin administration when there was a proposal to eliminate the expansion of Medicare, that these were just Medicaid.
Yeah.
Welcome
Welcome to the club. Yeah.
But it was, these people are slackers. They just need to get off
Yes.
their butts and join the rest of the real world. And, when Dr. Shavli was talking about some more rural populations, when you have an older populations with some vulnerabilities, diabetes, heart diseases, it's how do you square that?
Well, what I don't understand, and Gene, maybe you can help me with this, because again, my limited experience with the Peninsula General Hospital was a long time ago. Texas, Tennessee, Oklahoma, Georgia, Alabama, and Mississippi, all very red states. And their rural hospitals are closing at higher rates than other places where their Medicaid was expanded. But yet, when the population of those states goes to the voting booth, they put people in office who are doing things that are against their health interests and their economic interests. And for the life of me, I've never been able to understand why that happens. Do you have? I mean, you've lived down there for 40 years. Why do people keep voting for politicians who are going to put in programs that are going to be against the economic self-interest of the people that they're supposed to represent?
Well, I don't think they think about the economics in healthcare. I think they're voting based on 3 or 4 issues. One is Second Amendment rights. They're voting for people who are on the side of the NRA, and they want to have their semi-automatic weapons. Another big issue is abortion. And another big issue is gender rights. And then for some reason, Hillary Clinton became demonized, and they really didn't like Hillary. And it's almost a religious concept against the Democratic Party. We've got this big divide between conservative and liberals, and it's a big issue, particularly in rural areas. I hate the word liberal and conservative because I don't exactly know what they mean. But I think that's the reason they vote that way. I don't think they're looking at economic issues or healthcare issues. In my county, they've got good health care so far, and they don't think about the rest. Now, there are other issues in rural health care. It's very hard to attract doctors, and there's been a great change in how doctors behave in rural areas. For example, when I went there in the late 70s, back to my hometown, most of the babies were delivered by family doctors. They would do their own C-sections. There was a doctor over in Marion County who would deliver over 500 babies a year. And he had a surgeon who would do the C-sections for him. You can't find any family doctors who will deliver babies anymore, mainly because they don't want to be tied up 24/7. And the other reason is malpractice issues. The other big issue is the general surgeon. The general surgeon is going to small towns where there's no other surgeons, is not going to do orthopedics. They're not going to do GYN because they're not trained to do that. As a matter of fact, we now have special programs in general surgery where a lot of people coming out of training, they don't feel confident, so they're spending another extra year in a fellowship in general surgery. Most general surgeries are subspecializing so that they can go and just do specialized surgery, because doing general surgery really takes a lot of talent, and most people feel very insecure in doing that.
Doctors, I'm sorry, this hour has flown by. I think we've just scratched the surface on both topics that we started with, and to be continued. Dr.
Yeah,
Flynn?
and again, I think as a final comment, as we talk about all these issues, it's a recognition that we really this system needs to change. And some of the issues that we talked about in the very beginning are the places we need to go. The question is, how do we get there?
Okay. Well, thank you all so much. Dr. Shively coming in from Campbellsville. Dr. Flynn, your long drive in from
Cherokee Park.
Cherokee Park.
You could have walked.
Let me say, for the moment, single payer radio can be heard during the community access hours. That happens for single payer radio the second week of the month and for the last week of the month. To get a reminder about this program, please sign up to Kentuckians for Single Payer Healthcare. You can go to kyhealthcare.org or send an email over to ktillo at nursenpo@aol.com, nursenpo@aol.com. We're no longer meeting twice monthly at the main public library branch, but we do meet by Zoom. So send Kay an email and we'll get you signed up. And if you like what you hear here on Single Payer Radio, please go to Forward Radio, WFMP 106.5. It's an all volunteer-driven community radio station, forwardradio.org. For Single Payer Radio, I'm Mark McKinley. Thank you very much.